Endocrine, basically, endo means from within, crinin means to separate, logo is the study. So we're looking at the study to separate from within, if you break down what endocrinology is and all that stuff. This is one of the multi-system systems. You have multiple, if you go back to biology and all that stuff, you remember everything from the pineal to pituitary to the thyroid. We have our thymus, which most adults no longer have a thymus. That's usually prominent only in the kids. So it doesn't really affect us, from that aspect. The adrenal glands, the pancreas, of course, is the big one that most people think about. And then from there, the ovaries for the girls and testes for the boys. We're going to kind of sort of talk about here the hyperthyroid stuff, which is a number of different pieces, a little bit of the adrenal stuff, and then ending it with the DKA or all the sugar stuff from the pancreas. So really only going to touch upon three major endocrine hormones or endocrine, all that stuff. So most of, when we're looking at endocrine problems, okay, do you guys actually make the diagnosis? No, okay. What's the one where that you guys could pretty much, without a fact on an endocrine problem, what diagnosis can you make? What system, what organ? That's what, kidney's not part of the out of these things. The pancreas stuff, okay. So without a doubt, you guys can diagnose a pancreatic problem, okay. So for those problems, and of course we'll get to that. Most of the time, everything we do is supportive. So it's not like we're really doing anything significant in the pre-hospital. But there are some of the cases, knowing the information, of course, is half the battle, and getting stuff to the ED doctor. And then there's an old adage, the mind doesn't know, the eyes can't see, the ears can't hear, the nose can't smell, the fingers and hands can't touch, okay? So if you don't know about it, then you're not thinking about it. And it's always, the weird cases are the ones to know and to be thinking about. So panhypopituitarism. Yeah, exactly. But going back, again, high school biology, the pituitary gland is the master gland, so everything is affected by the pituitary. Okay, if you're looking at things over here like ACTH, the thyroid stimulating hormone, luteinizing hormone or the follicle stimulating hormone for the sex stuff, and then ADH, which is the anti-diuretic hormone. This is the one that predominantly, if you're drinking beer and all that stuff, that kind of sort of affects, that's why you pee a lot. But getting into that later. So the pituitary does have a lot of roles for things. So inadequate production can, of course, affect things, and the clinical presentation can vary. When we talk about cortisol stuff or thyroid stuff, of course, if you don't have your sex steroids at an early age in life, that's why you get your dwarfisms or your acromegaly or the giantism, if they get too much sex steroids and all that stuff. So where the growth comes into play. Something want to know. You could just make this so interesting. All right. So word finds, the things that you're gonna be looking at and all. This is really what the endocrine system is like. Okay. If you could take and go through right in the dead center, of course, glands, the pituitary, pancreas, sex gland, adrenals, the parathyroids, the thyroids, and then it just blows up from there. Okay, this will be testing quiz later. Yeah, exactly. Bubbles. Everything from the simple fact of like down here and controlling blood pressure, having fat break down our immune systems. I mean, the endocrine system plays such a vital role in everything that we do. So if you really think about it, the nervous system is the highway system of our control, and then the endocrine is the waterways. So just it's a slower way of getting around, but it does get there. It has some transportation means. So thyroid, we basically have TRH coming from the hypothalamus going down to the anterior pituitary, which does TSH, which releases T3 and T4. T4 is the major one. And then from there, they're predominantly bound to protein in the bloodstream. Okay. And then ultimately, T4 is broken down or deiodinated to the more active form of T3. So people that have thyroid problems and they're really anxious, they have a lot of circulating T3. And the other thing to get into when we talk about what's the one concern for nuclear radiation and all that stuff. What salt do we give to people that have been potentially, if there's a nuclear disaster? No. Iodine. Yep. Yeah. We give iodine for potential nuclear stuff, and it's the whole purpose of it is to block. It's to help with the protection of the thyroid gland. So hyperthyroidism can occur for any age, usually less than 15 is rare. Females, of course, more prevalent than males for this. Graves' disease is the number one cause, and that's an immunologic problem. And then you can have other things, the thyroiditis, pituitary tumors, medications, of course, always play a factor into things. In the aspect of your potential things with thyroidism, this is the person that have the intolerance, they're sweating all the time, weight loss, the tremorous fatigues. Okay, so what type of what symptoms or what I'm blanking here. Never mind. Basically, what I was trying to get to is the aspect of the patient looks like they're having a whole bunch of epinephrine running around, or they have a whole bunch of adrenaline. For you guys here, treatment is not much except for getting them to an ALS provider. Okay, so paramedics and all for you, Mark, the aspect of starting IVs, giving fluids is about the biggest thing. Now, some of the the paramedics, instead of giving propranolol, they can give metoprolol or labetalol, one of the beta blockers. But the propylthiouracil or the iodine or the dexamethasone, that's really not much of options in the pre-hospital. Okay, so like everything else, the majority of the stuff treatment for you guys is what? Supportive care. Very good. Right. Yeah, no, you guys do support me well. So propranolol, what propranolol does is it decreases the heart rate, decreases the tremors, and then from there, propranolol by itself for the medics is that it goes through and it helps actually block the conversion of T4 to T3. All right, and then what PTU or methimazole, they block the synthesis of thyroid hormone. And then when we going back in the whole thing of iodine, is ultimately that stops the conversion and the breakdown or the formation of the hormone. And then dexamethasone, the last thing it does is it blocks the conversion. And the other things that we can do, and a lot of this is inside the hospital, which is taking plasmapheresis or charcoal plasmapheresis with pulling the circulating thyroids, thyroxines, all that stuff out. So again, Graves' disease is the most common thing that you see for someone that's hyperthyroidism. Okay. So they have exophthalmos. This is the bug eyes. Okay. Have you ever seen someone walk around? They got the big eyes and all that stuff. And then, of course, the second common thing is going to be the goiter that you'll see. Exactly. It is females. Sometimes they'll get the goiter, they'll get the exophthalmos problems, and then usually it's the female's third and fourth decade of life. Can also occur during pregnancy where the parasite is affecting things. Exactly. The parasite within. Thyroid storm is just another sign, so it's your hyperthyroidism with, okay, fever, tachycardia, mental status changes. So if you have that person up in the slot machines and they start acting weird, okay, and they have a history of thyroid problems, or if they're on Synthroid or something like this could be one of the things to think about. Okay? So again, what would you guys do? You get called up there. This is the interactive time. Okay. 1 second. Yeah.
I can hear you. Don't mute them.
All right, so yeah, so doing your sample history and all that stuff, of course, checking blood sugars and think about other potential causes. But again, thyroid storm is one of those things that you want to potentially think about. Okay. So goal stabilization, airway protection, oxygen, IV fluids. Can't really do that here, but on the outline. And then getting back into the aspect of treatment, it's for the medics and all that stuff. You know, beta blocker is one of the first things. Propranolol is the ideal drug, but you know, all that we're carrying predominantly is metoprolol. And the other three things really can't do much there. Getting to the hospital and letting the doctors know. My little bash on the 4. Yeah. Hyperthyroidism, again, getting back into the aspect females more than males. So the endocrine problems, most endocrine problems are more females than males. Unlike most everything else where males actually dominate the problems. Again, getting in the aspect of autoimmune, just like Graves' disease and hyperthyroidism. You have Hashimoto's thyroiditis is the most common cause or feature that you get for hypothyroidism. And then you have other things, idiopathic, or they can actually, if they take out the thyroid, ablate the thyroid, or if they have iodine deficiency. Okay, why doesn't America really have iodine deficiency anymore? What? And why is that important? No, why is it? What about the salt though? Yeah. So they back in the 60s they were seeing that people were iodine deficiency. So the Morton Salt Company started combining iodine into the salt. So that's why you have your history. And then of course anything postpartum with females and all that stuff. Typical the aspect of what they look like, they're dry core, thinning of the eyebrows, they get the paraorbital edema, and the puffy face and dry skin. Possibly. Okay, so you get called to a 65-year-old woman at a ECF for ultramental status and bradycardia. Okay. You first noticed today by the ECF staff. This is the typical 7 a.m. No one really saw her overnight. Okay. She has a history of a couple CVAs, does have hypothyroidism. She's on aspirin and Synthroid. Okay. So you walk into this room and you see this lady that's just basically laying there, unresponsive, bradycardic, cool to touch. What do? Sternal rub doesn't respond. What? Check for a pulse.
Thing I would do.
She has a pulse.
Make sure
She's breathing very slowly. And she has a slow pulse. Okay, non-rebreather. Blood pressure is low. Sugar is okay. 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 So Narcan doesn't do. She actually had normal-sized pupils prior to that. Okay. So get ALS rolling. Glucose check, O2. Okay. So what are we? This is an endocrine problem. So what type of endocrine problem? This is a worst case type endocrine problem. Sugar is normal. Nope, breathing's just shallow, slow. No one here? Okay. Blood pressure's low. So everything's low. So blood pressure 80 palp, respiratory 10, temps 92, pulse 44, cold to touch, minimally responsive. What's she protecting her airway? Okay. Rescue guard, using the spring. Okay. Yeah. Anybody know what condition we're talking about here? Endocrine-wise? Right. Myxedema coma. I know. This is why we're doing this. Okay. Not all of them do. Now, again, this is patients that have hypothyroidism, and most of the myxedema comas are the 60s, 70s, 80-year-olds. Okay. They have long-standing hypothyroidism, geriatric population, comatose, and all that stuff. And usually the big thing is getting. Okay. We know that most older people, they'll get some form of infection, and then they have problems. But of course, medical compliance, non-compliance, they don't take their Synthroid or something like that. All right. Cold exposure is another factor, especially in Toledo, Ohio. And then any different medications, all that stuff. So again, just going to the aspect, their mental status, hypothyroid, or the hypothermic bradycardic, not breathing well. So the exact opposite of your thyroid storm. So thyroid storm is fever, altered, tachycardic, sweating a lot. Myxedema coma is the exact opposite, hypothermic, bradycardic, hypoventilating. Because we know what is the purpose of the thyroid hormone? Wait, yeah. Metabolism? Okay. So the thyroid stuff is all about metabolism. Underactive thyroid. That's what most of them say anyways. Physical exam, of course, getting to the hypothermia, hyperventilation, tension, bradycardia, and then also mental status. Again, what you guys already talked about, ABCs, fluid restrictive, the hyponatremic, and then looking for any of the precipitating factors. Into the hyperparathyroidism, if you remember back into biology, where do the parathyroids lay? parathyroids, you have 4 of them. They're right into the thyroid, so they're usually indented little balls into the, you have each of the pole of the thyroid. If you remember, the thyroid looks like a little bow tie, so it's on the edges of the bow tie. And then from there, you have either a primary or secondary causes for hyperparathyroidism. Symptoms can be vague in the aspect of fatigue, weakness, vomiting type stuff. And then ultimately, for you guys, it's really just providing supportive care. They have the polyuria, polydipsia type things, dehydration. So a lot of it is all the symptoms of hypercalcemia, which we'll talk about in a little bit. So the the moans, groans, psychiatric overtones, so things that think about with hypercalcemia, anorexia, constipation, just because the calcium's not working. So on EKGs, one of the things to think about with the hypercalcemia, so a whole bunch of the parathyroid is increased, so its job is to basically leach calcium from the bone. Okay, so what it does is pulls the bones and it throws the calcium into the bloodstream. And what you get here is the QT stuff. So for you, looking at monitors when you're out in Oregon, okay, so you can even QT prolongation and all that stuff. Okay. So treatment for the hypercalcemia, the biggest thing is just, so if you're seeing QT prolongation or QT shortening for the hypercalcemia, is giving them fluids. A lot of times in the ER, I'll push Lasix as one of the first things, and then corticosteroids, but again, you guys don't have to worry about anything like that. Hypocalcemia, or the flip side of the parathyroid, if you don't have enough parathyroid hormone, this is when you get into the CATs, which is the convulsions, the arrhythmias, the tetanies, and the spasms. Okay. And the hypocalcemia, again, it's thinking about a endocrine problem. Okay. Usually a destruction of the parathyroids. Either they removed them or they were doing something with the thyroid and they cut it out. All you need is one parathyroid gland to be able to maintain enough calcium in the body. Some people, they take too much magnesium. Okay? So if they're having problems with constipation and they take the milk of mag, or they're not taking enough and all that stuff. The other thing, 125 dihydroxycholecalciferol, which is the vitamin D. Patients that we see with this is going to be your renal patients. Drugs can cause a lot of that stuff too. Okay. Uptake of calcium, so they have poor calcium and bone disease, hungry bone stuff, and then of course the binding of calcium. Blanking out right now. Exactly. Yeah, I'd have to look that one back up again. But the biggest thing, of course, the calcium binds into albumin is another piece of the puzzle. And then some people with pancreatitis. For those people that are transporting blood or they're working in the ER or something like that, one of my first patients that I saw, they went to a PEA, was after giving blood transfusions because the calcium, all the citrate in the blood products basically leach the calcium out of it. And that's how blood products are kept and all that stuff, is by using calciums. Okay. So in the acute hypocalcemia, the things that they're looking at. Oh, nothing. The QT prolongation is the first one that you'll see on the monitors. Hypertension, bradycardia. And what's the Chavosky signs or Trousseau sign? And that's back to EMS, if you guys remember. Okay. We'll show them in a second. So the aspect of the other complaints is just your perioral numbness, paresthesias, muscle cramping. Patients can actually have seizures because of low calcium levels, which again goes back into the cats. Okay. So they both deal with the nerves. Okay. On the Chavosky sign, what you do is the buccal. It's the masseter muscle. So if they have low calcium and you tap on their cheek, their cheeks would actually spasm. Unlike the Trousseau signs of the carpal pedal, the carpal, if you were to tap into their middle, their hands will contract. Yep. And I was just showed a good YouTube video of this. I have to download that later for this. So yeah, if you just tap on the wrist, their wrist and all that stuff will flex. EKG wise, again gets into the QT prolongation for the hypocalcemia. So anything over 0.46 is the biggest thing. Questions so far? That's about the thyroids, the parathyroids. All right. Everyone staying awake? Hard? That's endocrine. That's fine. Into the adrenals. Okay. So adrenals, there's two pieces for the adrenal glands. You either have the medulla or the cortex. So the cortex is your salt, sweeten the sex, versus the medulla is your stress. You have three hormones produced in the cortex, the GFR, which is that's basically how the layering of it is. And then from there, the medulla, your epinephrine, your norepinephrine. So if you think about the location of the adrenals, they sit like a little on top of the kidneys. So how you put a little beret hat on, it just flops over. That's what the adrenals look like. They do look yellow in nature if you were to go in and cut them out. On cortisol, typically response, or this is part of the ACTH from the anterior pituitary. In ACTH releases it for trauma, infections are the major problems, but also at times when we have hypoglycemia, and then anytime you increase epinephrine. So every time we have a catecholamine surge, ACTH is released. So the function of cortisol, of course, is the decreased glucose uptake, the fat breakdown, and then from there it governs partly with the water stuff. And the next one, the mineralocorticoids, also has effect in that. Catecholamines, or it actually helps with catecholamines and all that stuff. Giving good contractions to the heart, constricting the arterioles, and that helps with blood pressure. On the salt, okay. Your middle, the major one is aldosterone. This is where you get into the renin, angiotensin, aldosterone system from the kidneys. So we don't have enough blood pressure, okay, or you don't have enough fluid. So what the kidneys sense that, and it causes the renin, which in turn causes the release of angiotensin from the lungs, and then back to the kidneys, or with the release of the aldosterone and all that stuff. Increase in sodium reabsorption and kicks potassium out. So wherever sodium goes, water follows. So that's what increases our blood pressure and all that stuff. And then, of course, the androgens, part with the sex metabolism and all that stuff. You have two different types of adrenal stuff, either primary or secondary, Addison's disease, or you can do the adrenal hemorrhages, which we'll talk about both of those, and then just failed from the pituitary gland. And diagnosing it for you guys it's not really a concern. That's more of into the hospital. JFK was probably the most notorious person with the Addison's disease or primary adrenal insufficiency. And again, it's just a destruction of the renal cortex. And they're thinking that it's most likely autoimmune. They do have some cases known with tuberculosis and fungal. So potential rise or potentially seeing more of this with an increase in tuberculosis that we're starting to see more of, secondary to HIV. So in the bilateral adrenal hemorrhages, the most common one is called Waterhouse-Friderichsen syndrome, which is the toxemia, septicemia, which I'll show you a picture in a second. Other things, though, patients that are on heparin, so your dialysis patients. So if they're coming in and they're having problems, they can actually see one of the pictures in a second, where they just basically the body is shutting down. Okay, and they get this is the non-blanching, non-palpable type purpura that you see more common with the meningotoxemia. Okay, so they're good 1 minute, and 2 hours later they look like this, and they're clumping in front of you. Yeah, quick. Don't. I've never felt it. Yeah. So this is severe case of meningotoxemia. They're dead within 12 hours from onset. Hypertension, pain, of course, epigastric pain, have vomiting, nausea, and then, of course, all the mental status. And again, this is from the aspect of where you're destroying the cortex. You don't have the cortisol anymore, and you don't have the mineralocorticoids. So that's why you're intensive. And then, of course, the cortisol with blood sugars and the altered mental status. So on the overall aspect of your mineralocorticoids, of your primary adrenal insufficiencies, okay, weight loss, abdominal pain, diarrhea, the brownish pigment, why do their skin look a tan color? And back to high school biology. This is where you're, again, if you're getting back into the feedback loops, okay, the primary hormone that increases the adrenals is partly the melatonin and all that stuff, yeah, but it has a factor. Your ACTH, okay, the adrenocorticotropin hormone, it has a factor with melatonin and all that stuff. So it increases that, and that get the pigmented skin. And of course, any of the loss of the nail beds and axillary hair in the females and all that stuff. So in cortisol, when we lose that, we get anorexic, nausea, lethargy, the hypoglycemic, and then shock just from minor stressors. When we lose aldosterone, we're dehydration, hypotension, and then any of the or even problems with cardiac output. Anorexia is anorexia bulimia is a psychological thing. Anorexia is I don't want to eat. So their appetite, they don't have appetite or anything like that. And then azotemia, where you have basically swelling in the body and all that stuff. So in the labs, not much for you guys. Check glucose, and then for EMS crews and all that stuff, looking at the ECG via flight and T waves, prolonged QT prolongation, low type stuff. On secondary or tertiary AI, secondary is usually just obstruction of the pituitary. Tertiary, of course, is one step higher, so the hypothalamic dysfunction. So getting really into the brain. And the aspect, though, aldosterone is not affected because the getting back into the feedback loop, the running angiotensin aldosterone system, that but you can have hypoglycemia and all that stuff. So the couple of the syndromes, Cushing's disease, have you guys heard of Cushing syndrome? Yes, no, maybe so. Brad? Okay. So what do patients look like with Cushing's disease? Bueller? Okay. Dry sunken, yep. Okay. So they get the they get the moon face, the round face, the humpback, okay, which is the buffalo hump. If you look at their belly, they get distended abdomen. They have the purple striae. The pregnant females, how they get the streaking and all that stuff. Ecchymosis, they easily bruise, thin skin, and then slow wound healing and all that stuff. Kind of, sort of. This is going to be your moon face, and sometimes it's a little reddened and all that stuff. So for you guys, the aspect of management is just caution because of the fragile skin, and then anything else treatment-wise, you know, if they have sugar problems or something like that, then taking care of that. Yes. That's Monday. Yeah. Margarita today. All right. So case 36-year-old patient with ultimental, taking steroids to control Crohn's disease, but she's been out of medication for 2 days. Okay. She's using high cortisone 5 milligrams, but she's out, and she's also on a couple other medications, allergies to penicillin. Heart rate 80, blood pressure 70/45, temperature is normal, GCS 11, dark pigmented skin, AccuCheck of 54. Okay. 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 Actually, 95% is my bad. Okay. Some glucose. How do I give her glucose? GCS of 11. Okay. Maybe a little square of oral in the cheeks. IV. Yep. Okay. What's causing all this? Okay. Is it the Crohn's acting up? Crohn's disease? Uh-huh. So adrenal crisis. Uh-huh. So the cause of it is if your patient's on long-standing steroids, they're long-standing glucocorticoids, so they're prednisone. Okay. And this is something that you guys might see here. So you probably have a lot of patients that are on a lot of the immunologic or the elderly patients. They're on prednisone, okay? And they're on long-standing prednisone, and they, go away, and they've been here for a couple of days and left the medications at home. They're like, oh, I can take care of this, right? And this is what you'll see. The nausea, vomiting gets into more of the lethargy. The hypoglycemic, the hypotensive. Basically, their body has been so used to having their oral glucocorticoid or the prednisone for so long that the body itself stops making its own. They have the brown color skin because you have no feedback suppression. And the aspect of that is they have, again, going back into ACTH, melatonin, and all that stuff. Okay. So cortisol and aldosterone can't be met. That's where you get the whole thing with the adrenal crisis. How'd you get here? Iatrogenic. Usually we give it to them. This again goes back into the aspect of the prednisone. This is why you always hear patients, they're on a prednisone taper. The patient on 14 days of prednisone or something like that. Because anything over 7 days, we know it's a problem. Trauma, surgeries, burns, pregnancies, of course, the other big one. Infections, trauma, surgeries, of course, going back down to the whole thing, lack of medications and all that stuff. Diagnosis treatment, of course, pre-hospital, just take care of the hypertension, given sugar, supportive measures. And then into the ED, we give them hydrocortisone, something like that. Fluids, all depending on what it is, D5 normal, normal saline, dextrose, correct the blood sugar, correct the blood pressure. Yeah. Questions? Okay. So again, an aspect of going from the top down, we've talked about the thyroid, the two symptoms of things, getting into the Graves' disease or Hashimoto's thyroiditis. So they're either having a thyroid storm, rapid temperature, blood pressure, heart rate, all that stuff, fever, all status, versus the Hashimoto's where they're slowing down. Then, of course, the worst problem with the thyroid is getting into the thyroid storm is the worst for too much, is the myxedema coma, okay, for too slow. Then we talked about the parathyroid, either too much or too little, and that's a lot of it has to do with calcium. And calcium we can see what with on EKGs? What? QT stuff, okay? So the QT is either really slow or really long, really long or very short. So in hypocalcemia, you'll see short QT. Hypocalcemia, you'll see a long QT. Then we just talked about the adrenal side of it. So you can have your primary or secondaries, okay, depending on and we didn't talk about the medulla, damage of the medulla. Of course, all that's with your epinephrines and norepinephrine, but you usually don't see a problem with that. So getting into Addison's disease versus Cushing's syndrome, okay? Addison's is usually more with where you have aldosterone problems. The Cushing's is with the glucocorticoids or the sugar problem, moon face. The last organ we'll talk about, the pancreas. Or do you guys want to take a break? Okay. Pancreas, just the aspect of, has multiple organs. The pancreas actually both has an endocrine system and an exoderm system, where the part of it is, it doesn't stay within the blood system, and actually all of your digestive enzymes get dumped into the intestines. But then from there also has your insulin and your glucagon, and that's where the endocrine piece of it comes into play. Yes? No. The major correlation with pancreatic cancer is smoking. That's the huge thing. That, or they'll have, or they've had pancreatitis, which in turn leads to their the cancer and all that stuff. And that can, of course, can be anything for your pancreatitis as your alcoholics is the most common cause. You can have idiopathic. There's some known cases of scorpion bites with pancreatitis and all that stuff. Arizona. So your pancreas, of course, is broken up into multiple different types of cells, the alpha cells or the beta cells. Alpha is your glucagon, which raises your blood sugar, and your beta cells is going to be your insulin, which lowers your blood sugar. So that's your islets of Langerhans. Remember that. Important. Yeah. Glucose, primary energy source. We can get it from multiple different ways, multiple foods prominently, but we get it from the liver with the gluconeogenesis, and then it's do have some stored stuff in the glycogen in the muscles and the livers. So this is the thing where if we can't get sugar into them, we can't get an IV, the medications that we give. Correct. Okay, giving them glucagon. Okay. So in a patient that is in liver failure or your chronic alcoholics, what's the problem with them? They're depleting, yeah. So they're depleting the sugar, okay, but they don't have the glycogen stores. So if they're already, if you get on scene and you have someone that's a chronic alcoholic and you can't get an IV in, and their blood sugar is low and you want to push glucagon, it might not work because it's not going to increase their glucose levels. You can give them oral. Yeah, they need oral or they need IV dextrose. But if they are altered and you can't give them oral, and that's something to take into considerations if you have those patients. Insulin produced by islets, the beta cells, used to help sugar. So sugar can't cross most cells' membranes. Okay, so that's where the insulin comes along, and it actually acts as a traffic cop or a school bus monitor, where it actually takes the insulin and it helps the insulin get across. Of course, the brain doesn't need it. It has its own abilities. Insulin stimulates fat production, glucose storage, decreases glucose production, and it helps decrease protein and muscle breakdown. It's the building up type hormone. Insulin builds up, glucagon and epinephrine basically break down. Okay. So after running a marathon or after you just had a scare, okay, someone scared you, and you tested your blood sugar, it would be elevated because of the epinephrine release and all that stuff. And again, why do we want a lot of blood sugar in our system if we're scared? Correct, for the fight or flight symptoms, okay? We need all that sugar there to be able to have it, to break down, to build ATP for energy to get the heck out of there. All right. So there's method to the madness. On the fed state, you can, after 3 hours after feeding, you have increased insulin carbohydrates are converted to storage. Fasting state, about 4 hours after. Within the 4 to 24 hours, you actually start seeing glycogenesis from the liver and all that stuff, which is the breakdown of your glycogen stores. So if you're not eating all that stuff. Anything beyond 24 hours, you have gluconeogenesis, where they actually take amino acids from your muscles and start converting it into glucose, or actually the glucose type medication or glucose type complexes. And that gets into the Krebs cycle, which I don't think you guys want to talk about right now. Okay. 3 a.m. We probably had all these. 22-year-old, seizure activity. Sister noticed shaking in the sleep. He's an insulin-dependent diabetic, NPH less than April. No allergies, denies any drugs, alcohol, tobacco. All right. Vitals are stable. Physical exam, he's confused. GCS of 12. Sugar's 35. All right. What's wrong with him? Why? Okay. Or
Or it could be a seizure burned it.
no fever. He's just confused. Yeah. Okay. So, or what if he didn't? I mean, he's just on a long-acting insulin. Okay. Didn't take any extra insulin. Meters broke. Okay. He sees though. Let me see this so often. This is a common thing. Why do patients seize when their sugars are low? Okay. What needs glucose? What body system needs glucose? It can only use glucose. They can actually use amino acids and all that stuff. You're thinking too hard. Yes. The brain. Okay. Yep. Yep. So the brain that's the primary organ that needs glucose. It can only use glucose, and maybe a little bit of ketones later in life when we get to DKA, but that's a different story. It doesn't produce its own. It doesn't need insulin to get it. Yeah. So the brain doesn't have glucose, so it gets pissed off and it sends off all electrical problems, and that's why you seize. So the hypoglycemia definition, of course, is less than 50. In our protocols, less than 60. The other thing, though, is are they having signs and symptoms of hypoglycemia? Meaning, are they shaky, fast heartbeat, sweating, dizzy, anxious, headaches? They're ill. Okay. What medication can some people, predominantly older people, take that can blunt this symptoms? Make it so it doesn't show. And you have a whole bunch of people upstairs right now that are probably taking medications like this. Not blood thinners. Beta blockers. Yep. So remember the beta blockers. Okay. So anyone on a beta blocker, they can have problems. So in the aspect of protocol-wise, if they're having low blood sugar, and you give them one of the things with epinephrine, if the epinephrine doesn't work, or the glucagon, because the glucagon reverses beta blockers. All right. So something to take into considerations. that they might not be irritable, they might not be anxious. Because all this stuff is they're not shaking, because that's the release when you get into epinephrine release or the adrenaline release. That's why they're shaky, that's why they're irritable, that's why they're anxious. Okay, they could just be out of it. But that's all that you're going to see. Causes, of course, oral medications. There's a whole more to the list. Insulin, overdose, liver disease, alcoholics, people that just don't eat toxic stuff, kids that do Skittle parties and they just dump their mother's beta blockers or calcium channel blockers into the bowl. Of course, infections always has a problem. So, yes, you guys are right. They haven't eaten their last meal. They took their insulin and then they drop. Or they've had their medication dosages changed and all that stuff. Meters reading. Yep. Improper meters and all that stuff. Okay. So the aspect, if you think about it, two different pathways. The brain doesn't go, so that's where you get the altered, the seizures, the headaches, or the other aspects with the adrenal glands that cause the release of epinephrine. That's where you get the tachycardias, the blood pressure issues, the sweatings, the nausea, and all that stuff. Pale skin, all that stuff. They kind of sort of look like a insulin shock, or they have that's the term that they use sometimes, that they're an insulin shock. So on the neuroglycopenic versus the hyperepinephrinic, anemic, that's just the aspects of what they're looking at, same things that we talked about. Mental seizures versus the nervous irritability. Treatment, of course, 15 grams, 25 grams per kilogram for the pediatrics. If you can put IVs in, D50, 1 to 2 mLs per kg, which is usually an amp. Pediatric population, D25, 2 to 4 mLs per kg. And then if they're under 10 kilograms, of course, just remember to use the D10 or D12.5 if you're going to half dose the D25. Glucagon if you can't get IV access. And I'm working out right now potentially for EMTs to be able to do intranasal glucagon. So in the future, potential for you guys. And that's purely for the simple fact that so often you guys get on scene and can't do anything because they're altered and they have no gag reflex. Nope, it's all liquid. And then if you think about anyone that has the nutritional deficiencies, it's, give them the thiamine. And that's just to help prevent the Wernicke-Korsakoff syndromes. IQ check, 30 minutes, the next couple hours. Any patients that's taking oral medications that are hypoglycemic, where do they need to go? What? No. What location do they need to go to if they're on oral medications and they're hypoglycemic? Yes. Thank you, sir. They must go to the hospital. They can't stay home. They can't sign off per the protocol. X equals what? Yeah. Yeah, true. All right. So the diabetes, we have two types. Which is the traditional. There was the juvenile onset, or the type 2, which is the adult onset, which we know that is no longer true. That's why they changed the names from juvenile onset or adult onset, type 1, type 2. Different causes for it, secondary causes, of course, alcohol, cystic fibrosis. What was 45? Yeah. Gestation, and of course, getting into gestational diabetes. Squirrel. All right. Type 1, getting into that, it's no longer the adult, or sorry, the juvenile onset, because we have adults that are now that develop type 1. And this is the insulin, they have insulin problems. Usually those adults that develop the type 1s, they were type 2, and then their pancreas just stopped working altogether. It says, I'm done, I give up. Predominantly, autoimmune is the major thing. Infections, breastfeeding issues, diet, socioeconomic status always plays a factor. Unlike type 2, this is the insulin production, and a lot of it is they have insulin resistance, meaning their body's still building, they're still making the insulin, but it's just not working well enough. Usually that's controlled with diet, oral medications, and then ultimately, if it gets bad enough, getting into the insulin injection. So type 2, usually these are patients, sedentary lifestyle, over 50, history of blood pressure problems, their B's, infections, and their blood sugars, usually to the greater than 126. In the U.S., type 1's males greater than females. Type 2 males equals females. Non-Hispanic whites. I just can't say Caucasian, but that's how it came about. Versus greater than Africans versus black versus Hispanics. Type 2 blacks with Mexicans and then Japanese. Native Americans are making a strong push for this. And then the whites. On the type 1, of course, it's just the aspect of we have the loss of the beta cells, okay? And what's produced in the alpha cells? Beta cells is insulin. The alpha cells is glucagon. Yeah. That's where your alpha cells are. And type 2 is just the insulin resistance. Most people, for the first time coming in, if they're a type 1, and this is your 4-year-old kid that is complaining of polyuria, polydipsia, they're peeing all the time. I don't know, everyone's had stories of family members or friends or something like this. Okay. Versus the type 2 slow and insidious. These are the patients that they've been on steroids or something like that long time, or they just eat and eat and eat and eat and eat. Most of the symptoms, of course, just their polyuria, polydipsia, polyphagia, fatigue, weight loss, blurred vision. They can have their vaginitis, candidal infections. They get the candida under the breast, under the skin folds, and all that stuff. Symptoms greater than 200, plasma, glucose fasting greater than 126. And then, of course, there's a couple other ways to test for it. Other medications, diuretics, convulsants, beta blockers can have a problem with this. And then, of course, non-compliance is always a huge factor. So on the acute hyperglycemia, okay, for you guys, not much to do with your guys' protocols, okay? For the advanced EMTs, paramedics, you can, of course, put IV in, start IV hydration. Try to dilute it down. Just remember that it takes time to get there, so it takes time to. We don't correct someone's sugar rapidly. There's a couple problems that can occur with rapid correction, which we're not going to talk about. Complications, of course, with having high blood sugar is a lot. We all know this stuff. They have eye problems, kidney problems, nervous problems. Infection is a huge thing. This is the high blood sugar is the leading cause of renal and then hypertension with it. That's why we have a lot of blacks, that have a lot of them are on dialysis and all that stuff because they're prone to both having high blood pressure and sugar problems and all that stuff. So a couple things just with the insulin pumps. This is the newest thing that's been around for 10, 15 years now. New advances now that they are what it can do, and basically the pump is a little mini pancreas. Can malfunction occasionally. Dr. Newmeyer talks about his cases that he's had before with himself, and then from there, if you do have a patient that's on a pump, of course, and if they're low or something like that, first thing to do is just take them off the pump. It has right here in the port, just grab that and it just unclicks, or even just see if you have to pull it from the port site and all that stuff. Different measures, different pumps have different ways they can actually, some of them are sensing now that they have a little implanted device. That it senses the blood, and then it squirts out what you need. So again, just like what you eat, and yeah, so from that aspect, it's really it's amazing what some of these things are doing now. Yeah. Okay. The 53-year-old patient, worsening vomiting, headache, abdominal pain, 12 hours. She's been seen for several episodes before. Now with dyspnea and sweating, no chest pain. History, diabetes, arthritis, hypertension. She's on glyburide, insulin, aspirin. Okay. Heart rate 150, respiratory tachy, diaphoretic operating, hyperventilating, mucous membranes, and your acute check reads high. High. That's all you get. High. Yeah. Yeah. Yep. So your acute check says high. So what does this patient have? High blood sugar. Specifically, what does she have? Okay. And what condition does she have? She's a type 1. Well, she's a 1 and a 2. Nope. No. That's why her sugar is high. So again, the aspect of not all, it's not the DKA is not a young thing. Okay. Anybody that's on insulin could potentially have problems getting the DKA, or the diabetic ketoacidosis. You guys remember the Kussmaul's breathing? Okay, so that's the rapid breathing that they get from that. So in DKA, there's 3 pieces of it. They have the ketone production, they have the acidosis, which is the diabetic, which is the glucose, ketone, acidosis. Those are the 3 things that you have to have for DKA. And really with this, predominantly it's seen more into the younger, truly insulin dependent are the ones with the DKAs. But I've seen patients DKAs being on oral medications, and then that's not longer working. They're supposed to be, that's one of the telltale signs to be on insulin and all that stuff. So cells starve, they develop gluconeogenesis and glycogenolysis. That's where you start getting into the fatty acid formation. You have increase in the glucose, which causes osmotic diuresis. These are spilling the glucose and it pulls the water with it, and that increases all the problems. The body doesn't know what to do, so it starts increasing your aldosterone, which starts picking up potassium because it's trying to save water. That's where you get your elevated sodium levels and all that stuff. And they go into what's called a hyperchloremic acidosis. Too much fluoride ions. Stress, infection, we don't know why, but there's a huge factor that plays into it. Of course, sugar greater than 250, and it's clinical. We know, yep, blood sugar elevated, they look like crap. Okay, they're in acidosis. I don't really care what caused it. But then from there, you guys won't test for this stuff, but this is what we're testing for in the ED. Treatment fluids, some can be down 5 to 10 liters. Usually you get the first liter for advanced and paramedics and all that stuff. After that, it's slowly hydrating. You don't want to really drop them too fast. The cerebral edema and all that stuff. Specifically kids. Bicarbonate, usually in the ER, we don't really use bicarbonate much anymore, unless they're under 7. So they're really acidotic. They're even down to the acidosis to 6.9, where we're even giving bicarb. Complications, infections, MIs, of course the therapies, because we're giving the insulin, which will cause the hypokalemia. Cerebral edema is the worst case scenario for driving their sugar down too fast. The brain will swell, again goes back into the osmotic diuresis and all this. And then infections and shock. Okay. Got a 100-year-old diabetic, demented, just not acting right. Okay. 135, 80, reads high. Again, she's mucous membrane's dry. She's on just glucophage, not on insulin anymore. Okay. And she hasn't been eating, and they only changed her fully bag 3 times today. What does she have? Dehydrated, yep. Okay. So start the IV. We know kind of sort of that she's hyperglycemic. Okay. Is she in DKA? Yes, no, maybe so. Or is she in a different syndrome? Okay. So there's actually something that your non-insulin dependents, older patients get, okay, called HHNK, hyperosmolar glycemic non-ketotic syndrome. What they do is they have everything similar to a DKA patient, except they're not still in ketones. Okay, they still have enough insulin in their body to push it across so they don't have the fatty acid breakdowns, which in turn that's what causes the ketone production. Diabetics, infection is the most common cause, older patients, but you can see it in dialysis and all that stuff. And some people on the parenteral nutrition or the IV nutrition can also have this. So they're still burning the sugar, but they just can't get it and all that stuff. They do get the polyuria, thirst, polydipsia, and all that. Okay. So they don't have the ketone production. Okay. So for the ketones, I can't smell it. Some people can smell the fruity breath, so the nail polish remover, that's what the ketone. I can never smell it. And again, they're severely depleted, 68 liters down, just like the DKAs. questions on blood sugar issues? Hypoglycemia, hyperglycemia, anything like that? Nothing? All right. Couple quick things left, and then we'll get done. I told you, an hour and a half, roughly. Just remember the aspect of refusals and documentation of refusals. This is in the protocols. One of the big things to do is, patient. Okay. So you're diabetic, and what's the other patient population that you can sign off as a treat and release? Actually, the two other populations. The diabetics, asthmatics, people that's been tased that's going to jail. Okay. So just from the protocol wise, everyone else for the most part, in my opinion, is an AMA.
So I'll say here, safety,
Yeah.
I know it's in the protocol.
Uh-huh.
They go to hospital.
No, if they meet criteria again. And the criteria is over 18, not complaining of any chest pain, they're not on any drugs, they're not altered.
No, they're gonna come.
Well, if they're complaining of chest pain, then yes,
Yeah.
that's part of the protocol. They have to go to the hospital to get checked out. I mean, if they're not complaining of anything, then no, they don't need to go to the hospital. And you watch them for 20 minutes, make sure that they don't have any tetany or any problems or anything like that. They don't need an EKG and all that stuff. So, but we diverge. If they have a heart problem, then yes, they should go and all that stuff. Not complaining of anything. Yeah, because there's the possibilities of problems. Yeah. So on the refusal, of course, with the diabetics, must be diabetic, insulin dependent only. If they're on oral hypoglycemics, that doesn't count. Oral hypoglycemics should go to the hospital just to be monitored. If not, you'll be back there in an hour or two because their sugar will be over 18, where they have a minor or a parent with them. They have no other medical problems. They're not a danger to themselves. They're not dependent, hypoxic, no traumas. So GCS greater than 15, and their conscious, alert, and oriented times 4. Of course, contact med control, questions for the diabetic to ask, risk illnesses on the oral medications. If you tell me, yeah, they're on metformin and they were low, guess what I'm going to tell you? You contact med control. I'm not going to allow you to sign them off. Medications, orals, and then from there, they have to have a family and friend. And then, of course, do they have an accurate acting glucometer? And sometimes, 120, but you get there, bless you. And yours said it was 50, so sometimes they might need to have the glucometer checked.
Took too much. 500, 100.
Yeah.
Powerful. What about one of these? 500.
How about you just all those and start over? Yeah. Patient to refuse, of course, informed consent, fill out the run sheet, document, and then meeting all the criteria. When to worry, no one to stay with the patient. Of course, you've been to the multiple visits for the same thing. I'm sorry. This is not the third time today. Time for you to go to the hospital. If they've had any medication changes on oral meds, and if they're on the long-acting insulin, which I'm plus or minus with that.